Jeff, should I?
Yeah, let me just make sure you can share. I made you as co-host, so you should be able to share your screen anytime.
Okay. And right, so you can see that now?
I can, just not in the presenter mode, so just put presentation.
Yeah.
Yeah, that's perfect.
Good. Thanks, JF. Yeah, no, this is an interesting topic, and it, on the surface, it may seem rather sort of esoteric and a rare clinical entity, but I do want to kind of emphasize today that this is I would consider quite common, and not just from the lens of an aortic surgeon, but we are confronted with this issue on a fairly regular basis. So, and I think it's important to have an understanding of how to approach this clinical problem. Um, so we'll quickly, I'll keep this rather simple and keep it to big, broad points for the general population, but feel free to ask questions as we go along. We'll briefly go through some concepts and definitions of pathophysiology, diagnosis, and imaging is playing a much larger role in managing these as imaging gets better, and treatment. And I'll try to illustrate with a couple of cases. And like I said, this is not uncommon, and it didn't take long. There's no shortage of cases for me to choose from. But I do also want to say that intramural hematoma, as discussed, you can't discuss intramural hematoma without including it in the spectrum of acute aortic syndrome, because that's really what it is. It is and should be considered as a part of an acute aortic syndrome. The concept of the acute aorta has been known for a long time, hundreds of years, and there are illustrations to depict it. I always find it interesting to see these illustrations in early history books. So I will illustrate our case with a couple, our topic with a couple of cases. They're not that dissimilar, actually. First patient is a 75-year-old male, sudden onset of typical chest pain, sort of a typical acute aortic syndrome presentation. And this was in the setting of type B aortic dissection, who presented with also presented with ascending intramural hematoma. And here, I'll highlight the scans on your right side. Is a scan 48 hours later, and we'll go through some of the imaging details later, but clearly you can see the type B dissection and this crescentic hyperattenuation of his ascending aorta. And at this point, we did not intervene, but 72 hours, again, we repeated the scan. And I'll emphasize, imaging is critical in the management of these patients. Subsequent scanning at 72 hours demonstrated an increase in size of this intramural hematoma, which you can appreciate here. And this is just another view of the ascending aorta, demonstrating the hematoma in the ascending aorta. Patient 2 also initially managed with usually conservatively managed with ascending IMH. This patient had a mild pericardial effusion and no further pain, and was admitted with good blood pressure control. Again, not that dissimilar. You can see the crescentic hyperattenuation in the ascending aorta, and a type B dissection. So again, emphasizing that intramural hematoma is in the spectrum of an acute aortic syndrome, a life-threatening condition of the thoracic aorta, often presenting with pain and hypertension. And in the spectrum is frank aortic dissection, which we obviously all know about, and the entity of penetrating atherosclerotic ulcer. And intramural hematoma, previously has been thought to be secondary to spontaneous rupture of the vasovasorum, and I'll go through some photos of that, and classically distinguished from aortic dissection in that the aortic intima itself remains intact. But I do want to remind you that IMH is classified just as dissection is classified. So type A IMH involving the ascending aorta, any involvement in the ascending aorta is automatically type A IMH, and only involvement of the descending aorta is considered type B IMH. And this has certain implications for how we manage these patients. IMH represents a significant proportion of acute aortic syndrome cases. And some distinguishing features in general are that patients with IMH tend to be older, more atherosclerotic disease, and less true aneurysmal disease, whereas those with type A dissection tend to have more aneurysmal disease. Several studies now indicate there, and this is an important point, there is no difference in mortality in patients with IMH versus those with aortic dissection. So this is why we treat these and take these very seriously. Just some pictorial depiction of the distinction between these two, with a schematic on the left and the radiology on the right, of true intimal flap and classic dissection with true lumen, false lumen separation, versus IMH, where you again have this only this crescentic hyperattenuation with no actual flap, and this entity of a penetrating atherosclerotic ulcer, where you see a ruptured ulcer causing the intramural hematoma. And one can go back and forth through these clinical entities at various time points in their presentation. Often I think, sometimes the aorta looks like, when you have IMH, that it actually is an ulcer that probably caused this, and you can't appreciate it on imaging. So obviously we know aortic dissection can occur as a unique entity, but can also result from progression of intramural hematoma, or, as I just said, an atherosclerotic ulcer. Again, I just want to depict some imaging of a classic type A IMH with this crescentic hyperattenuation. I'll go through the importance of imaging in these patients. And here you see it limited to the descending thoracic aorta. Just quickly, we all know that the aortic wall is made up of 3 layers: a single-celled intimal layer, the thickest medial layer consisting of smooth muscle cells and elastic tissue, and a thin adventitial layer, which is where the vasa vasorum originate and supply oxygen and blood and oxygen to the deeper layers. Pathophysiology is thought to be long-standing hypertension inciting and starting a sequence of histologic changes in the aortic wall, which includes smooth muscle cell hypertrophy, and changes to the vasa vasorum, resulting in some degree of microischemia and a stiffened outer media. Again, take-home point: IMH historically has been differentiated from aortic dissection. The intimal layer remains intact. Now, the thought of this has changed recently, and really this has been the prevailing thought because we haven't been able to appreciate intimal disruption in IMH. But more and more, and I've actually seen this in cases where more than one time where I've operated on those patients with pure IMH, and you don't actually see a dissection on imaging preoperatively, but you go in there and you do see an intimal tear. So I think this rather newer theory of small intimal medial tears and microintimal tears that actually exist producing IMH. Yeah, I won't go through all this, but again, some prevailing thoughts is that distinction can be made, on the left with dissection, where you have an entry tear and a re-entry tear further downstream, versus IMH, where you simply have an entry tear resulting in blood propagating in the medial layer without re-entering at a more distal point. Um, Again, I'd like to emphasize imaging is critical in these people, and you really have to know how to order a CT scan to visualize this. Um, and the best type of scan is a non-enhanced scan, and these often should be reformatted with slightly thicker sections than we normally do, so you can demonstrate the hyperattenuation in the media. And sometimes you can see calcium. Another clue on imaging is seeing displacement of calcium from the outer wall towards the center. And again, the natural history of IMH is extremely variable, being able to regress, resolve, or enlarge and progress to aneurysm, dissection, or frank rupture. Um, and there are imaging prognostic factors that indicate higher risk for complication or progression to complication. And these are kind of the general rules that I've used in the past and are in the literature at this point in time. And I'd like to make it clear, like, although I said earlier that the mortality for type A dissection and IMH generally is almost the same, we don't always operate on type A IMH like we do for type A dissection. And I'll explain that a little later. So those at higher risk are those with bigger aortas naturally. And generally, if they're approaching 50 or 5 centimeters or 50 millimeters, I'm more likely to operate on them. If the IMH is a certain thickness over 10 millimeters and or growing, it'd be more likely lead me to consider operative management. And the other aspect is focal contrast enhancement, whether it's an ulcer-like projection, as you see in the top right-hand image, or you see some blood contrast pooling in the media in the right lower image. And this is not uncommon to see, actually. Again, some other images that portend a poor prognostic factor and would lead us to likely operate. So as I said, in general, treatment strategies for IMH are similar to those for type A dissection. However, more recent studies and reports suggest that initial medical treatment in those with type A IMH is not unreasonable with close monitoring, blood pressure control, and repeated imaging, and potentially delayed surgery for those who develop complications. So again, I'd just like to take you back to patient one. This was a recent patient we had. This was IMH in the setting of type B dissection, but that's a common scenario we have. But even if you had just the type A IMH, you can see this. This is the one you'll recall was growing. And so based on that growth and the thickness, we decided to manage this patient by endovascular means. And this is his post-op imaging. And you can see the stent in the descending thoracic aorta with enlargement of the true lumen, thrombosis of the false lumen, and subsequent significant decrease in the intramural hematoma here. And this patient did fine and went home. And excuse me. And similarly, the same thing for patient two, again, treated with stenting of his descending thoracic aorta and improvement of the type A IMH. And excuse me. And again, if these people had isolated type A IMH and the same indication, like progression and worsening of imaging, unfortunately, for those, there is no stent option, and those patients would need a sternotomy. So just some take-home points here. In conclusion, the pathogenesis of IMH is controversial, but this sort of new theory of micro-intimal tears is becoming more and more thought to be the inciting pathology. And I think it's important to continue to think of this entity as an acute aortic syndrome in the same group, in the same cup as type A aortic dissection, and really do not underestimate its mortality. Um, Specific detail imaging is absolutely critical in managing these patients. I think they should all be referred here for follow-up management, treatment, and surveillance. And in general, conventional treatment for IMH continues to parallel that for dissection. And that's it. Thank you very much.
Thank you, Zako. I'll ask you to stop sharing the screen. This will allow us to open for question. I wonder if you could illustrate to everybody a little bit the sort of ballpark figure for mortality for acute aortic syndrome, all comers, and sort of try to just for people to get in their mind, you know, it's not a 1 or 2% mortality. It's not a, and regardless of the intervention, even in intervening in these patients for type A, for example, you're still looking at, you know, double digits mortality in these patients, even in the best of scenario.
I do think you can separate the mortality a little bit in acute aortic syndrome between the true type A dissection versus the rest. I think that's a whole different, you're right. I mean, that's still a 20% mortality, but I think these patients untreated certainly have, you know, 5, 10, 15% mortality if their blood pressure is controlled, then their pain isn't managed properly, they're not surveilled. And we've certainly seen these progress, and they can progress at an alarming rate. So the mortality is significant. Certainly, I wouldn't say it's 20%, but it's in the 10 to 15% range, I would say.
Yeah, I have a couple of questions. One from David Marr, really on the frequency of the scanning. So you mentioned scanning is key, and
Yeah.
you mentioned in your sort of on your first patient, certainly the imaging at 48 hours and then 72 hours. So clearly, lots of imaging was done. So how frequently should it be done?
Initially, very frequently. So yes, if they don't have a scan that is adequate when they get here, I scan them when they get here, and then usually at 24 and then 72 hours unless something else happens. And then after 72 hours, if nothing changes, I'll probably do it another week later. I do it on a case by case basis, and everyone's a little bit different. But the more imaging, the better, because like I said, these things change frequently and rapidly. So
Yeah.
we image them a lot. We keep them in the ICU or in our step down, and we follow them very, very closely.
I have another question from Sarah Melville around, you know, patients who are on anticoagulants like NOAC or DOACs. Are they more at risk of IMH? Are we going to see a change in how, you know, patients present, and your thoughts along that?
I have not seen that correlation personally, and I don't know if there's any data to suggest that. I think the largest risk factor remains hypertension, aneurysmal disease, atherosclerotic disease. As it stands, I don't think oral anticoagulation would make you more susceptible at that point to develop it. Progression, it may make you more susceptible to progression once you have it, I think. But that's just my anecdotal observation on this matter.
And along the same lines, obviously, patients presented with acute aortic syndrome and you are on anticoagulant, you're going to stop the anticoagulant. Now the question is, how long do you stop it for? And I guess it depends on what the indication for.
Yeah. Yeah, absolutely. I mean, if they're treated and like that patient one who had a stent and is presumably fine, I would be happy with starting him on. If he happens to be on anticoagulants for whatever reason, I'd be okay with starting him. If they're not treated and I continue to watch and surveil them, I'd be more reluctant to be honest, depending on the reason for their anticoagulation.
Yeah. Any other questions from the audience? Otherwise, Laiko, thank you very much. This is a little bit of an unusual problem, but clearly something that we are seeing more often, and we certainly asked to manage. And so from our cardiology colleagues, it's really around the hypertensive management.
Yeah,
We spend a lot of time acutely managing it, but these are often patients that end up on multiple agents and even central agents like clonidine for hypertension.
absolutely.
Some hypertension expertise would be really helpful in some of these patients for sure.
Absolutely. Yeah.
Anyways, thank you very much. Have a good day, everybody.
Thank you very much.
Bye-bye.